diabetes management in elderly part 4.
Now, if choosing to use insulin, clock drawing test can be used to predict who is likely to have problems with insulin therapy. Write numbers on the blank clock face and draw hands on the clock to show 10 minutes past 11 o'clock. So basically, इसको कितनी बार प्रॉब्लम हो सकती है इंसुलिन लेने में, वो आप प्रोटेक्ट कर सकते हैं इस मेथड के थ्रू. Now again, diabetes in long-term care. So undernutrition is a major problem with diabetes living in long-term care. Regular diets may be used in long-term care instead of diabetic diets or diabetic nutritional formulas. That's as per the guidelines. We've already discussed that. Now, treatment goals kya hai? So again, older adults who are otherwise healthy with fewer coexisting chronic illnesses and intact, again refreshing the same details as per ADA guidelines. So again, with fewer coexisting chronic illnesses and intact cognitive functions and functional status should have lower A1C goals, about 7 to 7.5. While those with multiple coexisting chronic illnesses, cognitive impairment and functional dependencies should have less stringent goals between 8 to 8.5. Glycemic goals for some older adults might reasonably relax as a part of individualized care अगर उनमें hypoglycemia chances ज़्यादा हों और acute hyperglycemia ना हो रहा avoid किया जा सके. Screening should always be done. So screening for diabetes complications should be individualized in older adults. Particular attention should be paid to complications that would lead to functional impairment, kidney failure, heart failure, cognitive impairment. So functional failure अगर हो रहा है तो उस पे particularly check करना जरूरी. Treatment of hypertension should be individualized as per target levels, as we had discussed previously. Treatment of other cardiovascular risk factors should be individualized in older adults, considering the time frame for benefit. So again, lipid lowering therapy and aspirin therapy may benefit those with life expectancies at least equal to the time frame of primary prevention or secondary intervention trial. That means कि अगर suppose आप आज ये चीज चेक करनी जरूरी है कि अगर आप आज उनको एक एटोरवास देते हो या रोजुवास देते हो, साथ में इकोस्प्रिन देते हो, तो उनकी लाइफ एक्सपेक्टेंसी आगे कितनी आप बढ़ा सकते हो. दैट मीन्स अगर किसी को मल्टीपल कोमोर्बिडिटीज हैं, स्टैटिन्स पे नहीं था, इकोस्प्रिन पे नहीं था और वो 85 इयर्स का है, तो उसकी लाइफ एक्सपेक्टेंसी कितनी है. अगर उसके हिसाब से आप उसको नहीं बढ़ा सकते, then there is no point of giving it. लेकिन अगर आप किसी 45 years, 50 years, 60 years के पेशेंट को अगर आप वो देते हैं, then you can extend the life expectancy of that particular patient. So that is important कि आप किस stage पे किसी patient को ये medicines, ये drugs provide advise करते हैं. Now again, this framework I think we've already discussed. Now that is as I was telling you. So again, healthy individuals may it should be fasting and A1C should be 7 to 7.5. Fasting and BP should be 80 to 130, and complex individual bedtime glucose should be between 80 to 180, and BP should remain below 140 to 90. Lipids में statins should be given unless contraindicated or not tolerated. Complex patient जिसमें multiple comorbidities हो या at least 2+ instrumental ADL impairment हो, mild to moderate cognitive impairment हो, then of course less than 8% की चलती है, and 90 to fasting glucose should remain between 90 to 150. Again, bedtime glucose should be between 100 to 180. PP should again remain between 140 to less than 140 to 90. And very complex हो या poor health है, किसी की life expectancy कम है, stage so again end stage chronic disease है, then again उसमें avoid reliance on HbA1c. So again, glucose control decision should be based on hypoglycemia and symptomatic hyperglycemia. Fasting glucose or preprandial glucose should remain between 100 to 180. Bedtime glucose should remain around 110 to 200. PP should remain below 150 by 90. And of course, Consider likelihood of benefit with statin. अगर statin नहीं चल रहा तो दे दो. Now lifestyle management कैसे करेंगे इन पेशेंट्स का? So again, optimal nutrition and protein intake is recommended for all older adults. In fact, for everyone. Regular exercise, including aerobic activity, weight-bearing activity, if in case it is possible, and or resistance training should be encouraged in all elderly adults who can safely engage in such activities. Safely engage. ये नहीं कि किसी को मतलब extreme emaciating syndrome, किसी को emaciating problem है, and then आप उनको बोलो weight उठाओ. So again, that will cause injury, unnecessary injury. So that should be avoided. For older adults with type 2 diabetes, overweight, obese, and capacity to safely exercise and an intensive lifestyle intervention focused on dietary changes, physical activity, and modest weight loss should be considered for its benefit on quality of life, mobility and physical functioning, and cardiometabolic risk factors. So quality of life, that's very important. Always look for quality of life. जितना quality of life पे ध्यान देंगे उतना better और holistic treatment आप patient का कर पाएंगे. As simple as that. So moderate to mild physical activity is also good. Now pharmacological therapy में, of course, in older adults with type 2 diabetes at increased risk of hypoglycemia, medication classes with lower risk of hypoglycemia are preferred. As we discussed before, sulfonylureas, meglitinides. So these classes of pioglitazone. So these classes should not be preferred. They should not be the first preferred drug of choice in elderly patients, especially sulfonylureas. Over-treatment of diabetes is common in older adults and should be avoided. कई बार polypharmacy, that's also a problem in older adults. So एक डॉक्टर से आया, एक कार्डियोलॉजिस्ट के पास गया, उन्होंने 4 दवाइयां लिख दी, एंड नेफ्रोलॉजिस्ट के पास गया, उन्होंने 3-4 दवाइयां लिख दी, एंड फिर एंडोक्राइनोलॉजिस्ट या डायबिटोलॉजिस्ट के पास आया, उसने फिर बेचारे ने 3-4 दवाइयां लिख दी. सो कई बार वो मेडिसिन जो है वो और बीच में पेशेंट फॉलोअप नहीं करते, 6 महीने किसी को दिखाया नहीं या साल किसी को दिखाया नहीं और वही मेडिसिन खाते रहे. So the problem is, और ऐसा कोविड के टाइम में बहुत हुआ. So over treatment should always be avoided because ultimately वो damage ही करता है और कुछ नहीं करता. De-intensification or simplification of complex regimes is recommended to reduce the risk of hypoglycemia and polypharmacy. It can be achieved within the individualized A1C target. अपने A1C target ध्यान रखिए, उसके हिसाब से ट्रीटमेंट दीजिए. एक्सेस में ट्रीटमेंट मत दीजिए, एक्सेस में मेडिकेशन मत दीजिए. It's as simple as that. Consider cost of care and insurance coverage. So हमारे देश में insurance coverage OPD में होती नहीं. However, अब कुछ insurance आ रही हैं धीरे-धीरे जो OPD करती हैं. But cost of treatment should be very, very, very important, especially when we are practicing in India. So of course, those medication which are not that costly should be given, and it should, so that the treatment, the whole treatment is adhered. Is basically follows adherence rule. So it should be the patient should adhere to you. Patient should comply to the treatment. That's very important. So again, this is simplification. This is an algorithm for simplification of insulin therapy. Just try to expand. Give me 1 minute. So again, it says a patient should be started on basal long-acting or intermittent acting or mealtime acting, short-acting insulins. So basal bolus, that is preferred. Premix insulin pe hai, so up to 70% of total dose should be given as basal only morning insulin dose. Mealtime, so again, change timing of the, so if patient is on bedtime or bedtime insulin, so usko meal time, so morning insulin पे करें. Fasting control में है, there is no reason कि वो bedtime पे रहे. So it should be titrated, and fasting goal should, so it can be titrated over a week, every third day, every once in a week, you can titrate the insulin. Fasting goal should remain between 90 to 150, and that can also be changed as per the health health category जो हमने पहले discuss करी थी. If 50% of fasting finger stick glucose values are over the goal, then again increase the dose by 2 units. If more than 2 times finger stick glucose remains above 80 milligram per deciliter, then the dose less than 80 milligram per deciliter, then the dose should go below 2 units. So it should be reduced by 2 units. So अगर हर तीसरे या थर्ड डे या once in a week आप मॉनिटर करते हैं, so इसमें once in a week है. So अगर once in a as per the latest guidelines, so अगर once in a week आप मॉनिटर करते हैं और उनकी ग्लूकोज कंट्रोल में नहीं है तो 2 यूनिट से बढ़ाइए. अगर ग्लूकोज कंट्रोल में है तो बेसिकली 80 अगर हाइपोग्लाइसीमिया हो रहा है 80 मिलीग्राम पर डेसीलीटर से कम है तो 2 यूनिट से कम कर दीजिए. मील टाइम ग्लूकोज के अंदर इफ मील टाइम इंसुलिन इज मोर देन 10 यूनिट्स per day, then reduce the dose by 50% and or non-insulin agent. That means अगर इंसुलिन पे पेशेंट है और उसको हाइपोग्लाइसीमिया हो रहा है, then you can reduce the sulfonylurea dosage. And of course अगर आप वीकली चेक करते हो तो उसके 50% ऑफ डोज जो है वो कम कर सकते हो. Then again, mealtime insulin dosage should be titrated as non-insulin agent doses are increased with the aim to discontinue the mealtime dosage, mealtime insulin. So again, दूसरा, if mealtime insulin is less than equal to 10 units per day dose, then again discontinue the mealtime insulin and add non-insulin agent. That means अगर किसी की requirement 2 यूनिट की है, total 6 यूनिट की requirement है पूरे दिन में या 4 यूनिट की requirement है पूरे दिन में, then there is no use. आप उसमें उसकी जगह non-insulin agents भी use कर सकते हो, pharmacological agents use कर सकते हो, if not contraindicated. That's very important. अगर eGFR more than 45 है, then of course metformin दे सकते हो, या फिर you can increase the dose every 2 weeks as tolerated. अगर eGFR less than 45 है, then of course metformin नहीं tolerate हो रही, then second agent like linagliptin, like DP4 inhibitors or even SGLT2 inhibitors or so any other agent can be used. So again, patient characteristics के हिसाब से we should be monitoring and we should be specifying the insulin dosage. So every 2 weeks adjust the insulin and do with finger stick method. So patient को बोलो SMPG करे, self monitoring blood glucose करे, और उसके हिसाब से weekly every 2 weekly you can check and you can moderate the dose accordingly. So goal should be 90 to 150 before the meals, and it may change as per the overall health or goals of care. 50% of pre-meal finger sticks remain above over the next 2 weeks. If they remain above the goal, then increase the dose by 2 units and or add other agent. अगर more than 2 pre-meal finger pricks they should remain less than 90. So again, the dose should be decreased. So elderly patients के अंदर as we want to remain in a safer range, so 90 milligram तक आप उसको titrate कर सकते हो. In meal time insulin dosage, basal में 80, meal time में 90, as simple as that. So again, जो HbA1c हमने discuss करे, उसका rationale क्या है? So again, उसका rationale ये है कि अगर A1C 7 to 7.5 हम healthy individual में ले रहे हैं, that means patients can generally perform complex tasks to maintain good glycemic control when health is stable. Again, अगर दूसरा, during acute illness, patient may be or may at risk of administration of or dosing errors that can cause hypoglycemia, falls, fractures, etc. Again, when may regime be simplified, or probably when simplification may be required. So if severe or recurrent hypoglycemia occur in patients on insulin therapy, if wide glucose excursions are observed, and if cognitive or functional decline occurs following acute illness. So अगर आपने CGM किया या आपने SMPG किया और आपने देखा कि acute hypoglycemia इस patient को हो रहा है, then that implies that should be the insulin dosage therapy should be modified. और de-intensification कब करना है? If severe and recurrent hypoglycemia occurs in patients on non-insulin therapies with high risk of hypoglycemia. Even if the HbA1c is appropriate. So अगर HbA1c आपका कंट्रोल में है, तब भी अगर किसी को हाइपोग्लाइसीमिया हो रहा है और रिकरेंटली हो रहा है, then the whole treatment should be then of course insulin or probably any other drug therapy should be changed. If wide glucose excursions are observed and in presence of polypharmacy, multiple drug doses, जैसे हमने डिस्कस किया था वो है, तो फिर उसमें चेंज करो. In those patients who have complex or intermediate कैरेक्टर्स हेल्थ स्टेटस, जो कि हम पहले डिस्कस कर चुके हैं. सो A1C गोल इज लेस देन 8%. कंसिडरेशंस ये हैं कि कॉमोर्बिडिटीज हों जो कि सेल्फ मैनेजमेंट एबिलिटीज को रिस्ट्रिक्ट कर रही हों. एंड अगेन लॉन्ग एक्टिंग मेडिकेशन फॉर्मूलाज कैन बी गिवन टू डिक्रीज द पिल बर्डन. I mean combination drugs, FDCs, fixed dose combinations can be given over here. So regime simplify कब करें? जब if again recurrent hypoglycemia या severe hypoglycemia हो. De-intensify भी तभी करें जब आपका on insulin therapy, और अगर insulin therapy पे है तो फिर de-intensify करें, de-prescribing करें, जब change करें पूरा treatment. Again if this patient is unable to manage complexity of insulin regime, and if there is a significant change in the social circumstances such as loss of caregiver, change in living situations or financial difficulties, और अगर सपोज ग्लूकोज एक्सकर्शंस होते हैं, पॉलीफार्मेसी होते हैं, तो पूरा ट्रीटमेंट चेंज करें. That's important. So again if the patient community dwelling में है, patient receiving care, so if again इस patient के अंदर you should avoid A1C as a specific glycemic target. So glycemic target should be 100 to 200 milligram per deciliter तक ग्लूकोज रखनी चाहिए, as simple as that, fasting वाली. So glycemic control is important for recovery, wound healing, hydration, avoidance of infections. Patient recovering from illnesses may not have returned to baseline cognitive functions at the time of discharge. Consider type of support at the patient. Type of support the patient will receive at home. So उनके पास घर में कोई ध्यान रखने वाला है या नहीं है, that is important to be considered. So simplify कब करना है? Where treatment complex है बहुत ज़्यादा उनके लिए during hospitalization, and it is reasonable in many cases to reinstate the pre-hospitalization medication regime during the rehabilitation period. If hospitalization, so अगर change पूरा कब करें? जब hospitalization for acute illness हुई थी, जिसके अंदर resulted in weight loss, anorexia, short-term cognitive decline, या loss of physical functions. Those patients who are very complex with poor health, so again उसमें A1C पे ध्यान मत रखें. और दूसरी चीज़ कि if on insulin regime, the patient would like to decrease the number of injections and finger stick blood glucose if the patient has an inconsistent eating pattern. इन patients के अंदर insulin 50-50 यूज की जा सकती है. newer insulins बहुत benefit देती हैं, जैसे कि degludec है या U300 है. So in fact degludec majorly, so उनमें बहुत ज़्यादा benefit मिलते हैं जिनमें inconsistent eating pattern. If on non-insulin agents, अगर hypoglycemia हो रहा है या फिर कोई cognitive dysfunction है, depression है, anorexia है, then of course पूरा treatment change करना जरूरी है. और अगर medication without clear benefits हो रहे हैं तो पूरी treatment change करें. अगर end of life पे है, then of course hypoglycemia should be avoided, and symptomatic hyperglycemia should also be avoided. Again, goals is to provide comfort and avoid tasks or interventions that can cause pain or discomfort to the patient. And caregivers are important in providing medical care and maintaining care of quality of life. If there is pain or discomfort, then of course treatment simplify करने की कोशिश करें. Or if there is excessive caregiver stress due to treatment complexity, patient wait करता रहता है, अगर जब मेरी nurse आएगी वो तभी injection लगाएगी, तभी medication देगी, उस केस के अंदर उसको जितना सिंप्लीफाई कर सकें उतना बेटर है. सिंपल क्योंकि हमारे HbA1c टारगेट जो है वो 8.5 से नीचे होने चाहिए, तो उन पेशेंट्स के अंदर we can just continue with the same treatment or probably keep simple drugs in their treatment regime. Again, तब change करें जब कोई clear benefits, पूरा treatment तभी change करें जब कोई clear benefits current medication के साथ ना मिले. तो उस time पे you understand that जो भी दे रहे हैं, जो भी medicine दे रहे हैं, it is not benefiting the patient at all. अब nursing skills, so again treatment in skilled nursing facilities and nursing home में कैसे होता है? So again, consider diabetes education for staff of long-term care and rehabilitation facilities to improve management of older adults and diabetes. ये majorly वहाँ पे काम आता है जहाँ पर home care होती है. Patient घर पे ही home care करा रहा है. So staff should know कि insulin देनी है तो कैसे देनी है, कहाँ पे लगानी है. कई बार मेरे patients में, कई बार मैंने देखा है कि जो nurses हैं वो जो साथ में आते हैं पेशेंट्स के ओपीडी में, वो हाथ ट्राइसेप्स पे, कई बार बाइसेप्स पे इंसुलिन लगा रहे होते हैं. ट्राइसेप्स पे थर्ड आर्म पे होता है, बट ज्यादातर नर्सेस को नहीं पता होता है. इट्स ऑलवेज वाइज टू टेल देम कि टमी पे लगाना है एंड अगेंस्ट रोटेशन ऑफ साइड जो है कैसे करनी है, खाने से पहले देनी है, खाने के बाद मेडिसिन देनी है, खाने से पहले इंसुलिन देनी है, वो सारी चीजें गाइड करनी जरूरी है. Patients with diabetes residing in long-term care facilities need careful assessment to establish individualized glycemic control and to make appropriate choice of glucose lowering agents based on their clinical and functional status. That's very important. Individualized. Individualized is the main important word over here. That should be considered always. So again, alert strategy ये है कि अगर hypoglycemia हो, then immediately the patient should take something. So again, glucose values less than 70 milligram per deciliter हो, that's very important कि वो कुछ मीठा खा लें and probably talk to the doctor as soon as possible. Then again, call as soon as possible also if the glucose values are between 70 to 100. Regimes may have to be adjusted. Glucose values are above 250 within 24-hour period of the treatment, starting treatment, so again they need to be adjusted. Glucose values are above 300 over consecutive 2 days, or probably if they are readings are too high on glucometer, then the treatment has to be adjusted again. And if the patient is sick with vomiting, symptomatic hypoglycemia and poor oral intake, the patient can go into HHS or DKA, and it's very important कि वो अपने डॉक्टर से बात करें. So again, palliative care is something which we have already discussed. So palliative care is needed for those adults with diabetes. The provider should initiate conversations regarding the goals of intensity of care. Strict glucose and blood pressure control are necessary, and reduction of therapy may be appropriate. So again, withdrawal of lipid lowering therapy may be appropriate in end of life care. So overall, comfort, prevention of distressing symptoms, and preservation of quality of life and dignity are primary goals for diabetes treatment in the end of life. So there are certain rules. So again, rules are that again, in a stable patient, continue with patient's previous regime with a focus on prevention of hypoglycemia and management of hyperglycemia using blood glucose testing, keeping levels below the renal threshold of glucose. There is very little role of A1C monitoring and lowering. ज़्यादातर patients में anemia भी होता है, तो इसलिए भी A1C monitoring does not give us a very clear picture of diabetes control. Chronic anemia की वजह से. So again, a patient with organ failure, preventing hypoglycemia is of greater significance. Dehydration must be prevented and treated. In people with type 1 diabetes, insulin administration may be reduced as the oral intake of food decreases, but should not be stopped. For those with type 2 diabetes, agents that can cause hypoglycemia should be reduced in dose. The main goal is to avoid hypoglycemia, allowing for glucose values in upper level of desired target range. And of course, in a dying patient, this may end of life here. Then again, for patients with type 2 diabetes, discontinuation of all medication may be reasonably approached, as patients are unlikely to have any oral intake, if in case it is the case. In patients को usually insulin पे ही रखा जाता है और रखना चाहिए. In patients with type 1 diabetes, there is no consensus, but a small amount of basal insulin may maintain glucose levels and prevent acute hypoglycemic complications. Now, these are generally, so apart from, so function, so again recommendation जो हमने पहले discuss करी, so again ये functional independent में life expectancy is more than 10 years, so वहाँ पे आप वो follow करेंगे, जिसमें BP target should be individualized for older adults who are functionally dependent and who have orthostasis and who have limited life expectancy. In again, that's the same thing. Yes, same thing. Class 1 test to receive diabetes education, and also emphasis should be given to tailored support and psychological support to these patients also. Apart from which, so they should be counseled well. Diabetes education and tailored and care should be tailored with psychological, psychosocial support. This we have discussed. So again, as in older people with type 2 diabetes, sulfonylurea should be used with caution. DPP4 should be used over sulfonylurea as second line therapy to metformin because of lower risk of hypoglycemia. Initial dose of sulfonylurea should be half the dose which we use in younger people. So again, and doses should be increased more slowly as we in fact, simply speaking, अगर किसी को 2 मिलीग्राम शुरू करने थे, 1 mg ग्लिमिप्राइड शुरू करनी थी तो 1 mg शुरू करो. 60 मिलीग्राम ग्लाइकोलाइजाइड देना था तो 30 मिलीग्राम ग्लाइकोलाइजाइड दो. अब तो 40 भी आता है तो 40 भी ले सकते हो. एंड देन स्लोली धीरे धीरे उसका इंक्रीज करो. एक साथ 90 पे मत शुरू करो, एक साथ 2 मिलीग्राम ग्लिमिप्राइड पे मत शुरू करो. Glycoside and glycoside and glycoside MR, glimepiride should be used instead of glyburide. Meglitinides may be used instead of glyburide to reduce the risk of hypoglycemia, particularly in individuals with irregular eating habits. So get short acting drugs. So again, in older adults with type 2 diabetes with no other complex comorbidities but clinical CV disease, and in whom glycemic targets are not achieved. So again, second line, second and anti-hypoglycemic agents with demonstrated CV benefit should be given. Determined U300, U100 may be used over NPH and 3070. Older people, pre-mixed insulin, pre-filled insulin should be used to reduce dosing error and to potentially improve glycemic control. बहुत अच्छे pens आ गए हैं U300 और Tresiba के, so they are very good and very easy. They have clear markings and with clicks, so that can be used very easily now. So again, regular diets and sliding scale, reactive and correction supplemental insulin protocol should be avoided in elderly LTCs residents with diabetes to prevent worsening of glycemic control. Reactive sliding scales are abandoned, so please do not use sliding scales in any patients at all for insulin. So of course, key messages that diabetes in older people is distinct from diabetes in younger people, and in approach to the therapy should be different. This is especially true in those who have functional dependency, frailty, dementia, or end of life. Personalized strategies and avoiding overtreatment is the key in these patients. In older adults with diabetes and multiple comorbidities of frailty, strategies should be used to strictly prevent hypoglycemia, which include choice of anti-hypoglycemic therapy and a less stringent A1C targets. Sulfonylurea should always be used with caution. DPP4 should be used over sulfonylurea, and long-acting basal analogs are associated with lower frequency of hypoglycemia than intermediate-acting or premixed insulin in this age group. In fact, in all age groups actually. So again, they should be given customized diabetes care plan. What works for one individual may not work for others. And again, based on the factors mentioned, so various factors which we have discussed. So selecting target glucose levels and accordingly the appropriate glucose lowering medication and screening programs should be individualized, and of course management of diabetes and their related complications should be individualized.